Good morning, all. I'll be discussing highlights from two of the studies which are HER2 positive. The first one is basically an extended analysis from affinity trial, and the second one is from the ADAPT. So coming to the affinity, adjuvant pertuzumab and trastuzumab in patients with early HER2 positive breast cancer in affinity, 8.4 years follow-up, and it was published in ESMO virtual plenary session by S. Loibel. So we all know the background of affinity, which was a phase 3 adjuvant study investigating benefit of pertuzumab when added to trastuzumab plus chemotherapy, which has two arms: chemotherapy plus trastuzumab plus pertuzumab versus chemotherapy plus trastuzumab and placebo. It has a primary endpoint of invasive disease-free survival, and the three main important stratification factors were nodal status, hormone receptor status, and chemotherapy regimen. So third interim analysis laid down a platform for the overall survival at a median follow-up of 8.4 years. So if we see the baseline characteristics, they were balanced in both the arms. If we see the nodal status, adjuvant chemotherapy and hormone receptor status, 2/3 patients were node positive and almost 25% patients had 4 or more nodes positive. Most of them received anthracycline-based chemotherapy and 2/3 were hormone receptor positive. So if we see the overall survival analysis at 8.4 in two arms, there was a minimal difference of 0.7%. And if we see the Kaplan-Meier curve, both the curves are almost superimposing. If we see the survival analysis in node positive cohort, there is a slight separation of the curves with a difference of 1.9% in both the arms. And if we see the node negative cohort, again the curves are superimposing with a difference of 0.9%. So if we see the descriptive IDFS analysis, we can see the slight separation of the curves with a difference of 2.6% in pertuzumab versus placebo arm. So the affinity third interim analysis, which laid down the platform for overall survival analysis, showed fewer deaths seen in the pertuzumab compared with the placebo arm. There was a difference of 0.7%, and there was a trend towards benefit of overall survival, which was influenced by node positive cohort, and follow-up is very important to determine overall survival benefit in pertuzumab arm. So if we see the cardiac safety in either of the two arms at 8.4 years of a follow-up, there were no new cardiac safety concerns. So the affinity laid down the impressions that node positive cohort derives benefit from adding pertuzumab. Hormone receptor status should not guide the pertuzumab treatment decisions, and no new cardiac safety issues emerge at this interim analysis. So the comments, it is clear that node positive cohorts benefited the most from the addition of pertuzumab. There is no data on 6 months versus 1 year of the combination, a food for the thought process. In current practice, node positive patients receive neoadjuvant therapy and dual anti-HER2, which is a reasonable approach. And questions in the neoadjuvant settings: do we continue dual anti-HER2 even after PCR is achieved? And with dual anti-HER2 blockade, whether the anthracyclines are really necessary. So my take-home message from this extended analysis of affinity is that in the Indian context, adjuvant dual anti-HER2 therapy should be considered for the node positive patients, irrespective of their hormone receptor status. Those with more than or equal to 4 nodes would appear to derive the most benefit from this strategy. Coming to my second abstract, that is from the ADAPT study, which was the author was Ulrich Nitz. So basically, we all are aware that there are several neoadjuvant de-escalation strategies to reduce the use of chemotherapy in HER2 positive early breast cancers. Majority of these studies actually use pathological complete response as a surrogate point. There are a few survival data from these studies, and the ADAPT, it aptly stands for adjuvant dynamic marker adjusted personalized therapy. So we all know the definition of PCR. What I like to emphasize here, the definition of early therapy response which was used in the study, it defined the early therapy response as proliferation decrease, that is Ki-67 decrease more than or equal to 30% after 3 weeks of therapy, or low cellularity in the 3-week biopsy sample. So this is basically a study design, and the study was divided into 2 arms, trastuzumab and pertuzumab given for 12 weeks, and another arm was trastuzumab plus pertuzumab plus weekly paclitaxel given for 3 months. And the primary endpoint was comparison of the number of patients with PathCR in patients with an early response in both arms, and the analysis of effect of PCR on the IDFS. And the secondary endpoint was distant disease-free survival. The baseline characteristics were balanced in both the arms. The results were, it was a study between 2014 to 15, 92 patients in TRAS plus PERT arm, 42 in TRAS, PERT plus Pacli arm, 60% patients had clinical tumor stage 2 to 4, 43% patients had node positive disease, and median Ki67 concentration was 50% in both the groups. PAM50 intrinsic subtypes were balanced, and the median follow-up in survivors was 59.9 months. So I'm so sorry for the poor quality of the graphs, but if we see these Kaplan-Meier curve graphs, first topmost is invasive DFS, second one is distant DFS, and the third one is overall survival. And if we see the hazard ratios, they are 0.35, 0.42, and 0.41 respectively. There are multiple Kaplan-Meier curves actually in the study, but I just summarize it in one table. And if we see all the parameters, whether it is IDFS, relapse-free survival, loco-regional relapse-free survival, distant disease-free survival, or events or deaths, trastuzumab, pertuzumab, and paclitaxel arm scores little higher as compared to only TRAST and PERT arm. So the conclusion of the study was, it showed good survival rates in patients with pathological complete response after de-escalated 12 weeks of TRAST, PERT with or without paclitaxel weekly. Omission of further chemotherapy did not affect the IDFS in patients with PATH-CR. 12 weeks of weekly paclitaxel with dual anti-HER2 blockade is an efficacious de-escalated neoadjuvant regimen in patients with hormone receptor negative, HER2 positive early breast cancer with high PCR rates. Overall, 5-year survival outcomes were not significantly different in two groups. So the further trials for this approach are ongoing. My comments at the end of the ADAPT study, it is an intriguing hypothesis generating study. It is a phase 2 trial, numbers are small though. However, if the patients are unfit for taxanes, it's necessary that they can get treated with trastuzumab and pertuzumab without greatly affecting the outcomes. So the limitations of this study basically included, despite a strong association between PATH-CR and survival, in basically the current analysis of 134 patients has little power to detect more subtle differences. The power is too low for interaction analysis of survival, and in particular, low number of patients with clinically N2 disease precludes the generalization of our findings in locally advanced early breast cancer. So my take-home message from ADAPT: chemotherapy-free anti-HER2 combinations are feasible and efficacious, though they are not ready yet for prime time. But yes, they can still be used in an exceptional circumstances. Thank you so much.